Hey Refam, my name's Kate and welcome back to Keeping It Real, the podcast that preaches the art of sometimes doing nothing. Today I'm joined by Richard and Kim as they share the dark side of over-investigating typical post-op bumps and twinges. They share some of the most harrowing stories we've ever had on the podcast, explain why seeing a patient in person is always the best way to diagnose, and we break down the most common post-op complaints operation by operation. As always, please rate and review if you're enjoying the podcast, and if you have anything you'd like us to cover, send your suggestions over to us on Instagram. In the early post-op days, I think patients can very regularly come in with just some niggling pain or some swelling or a lump or a bump, and might be something, might not be something, but I thought this would be a good time to kind of go through those common scenarios that people will see. I think surgery is very scary. It's not a normal experience for people. So if something's not going the way exactly they planned, it can be concerning. And for plastic surgery especially, you probably don't have somebody in your immediate circle that you can go to for a kind of yardstick. So let us be the yardstick. Richard, you've got a pretty set 3-tier category for these problems. Do you want to take us through it?
I'd just like to simplify it. So if someone's concerned about something after the surgery, I put it into 3 buckets. Bucket 1 is it's something simple, I know what it is, and you don't have to worry about it. Bucket 2 is it's something serious, I know what it is, and I need to intervene. And then there's the vast majority of patients, I don't know what it is, I know it's not serious, I know I don't need to do anything about it, and it's going to get better. But this is a big cause of concern for patients, and patients will sometimes leave a consultation like that and comment that I haven't listened to them or they don't feel heard. But the reality is just sometimes we don't know what it is, but we do know it's not serious and we don't need to do anything. So patients often are conditioned to have a problem, get some treatment, antibiotics, painkiller, whichever it is. And when they don't get that, they sometimes interpret that we haven't listened or we don't understand. But rest assured, for the vast majority of sort of funny feelings, pains, discomforts, anything, if we see you and you look and we know that you look okay, we don't necessarily know what it is, but that doesn't mean it's something bad and that it invariably will get better. So perfect example, consult today. I saw her a month ago. She was maybe a year after a breast augmentation and she started noticing some tightness in her chest. It had been intermittent. She wasn't really sure why it had happened. Couldn't remember doing anything, straining anything. It just didn't seem or sound or feel or look like anything serious. And I said, look, I don't know what it is. And I think she was worried maybe about capsular contraction. I just said, look, that's just not how it presents. I don't think it's that. Followed her up today, never had a symptom since that first consultation. It is by far the most common scenario that when I see you at a subsequent consultation, I will ask, what's happened with that pain? And the answer will be, you can hardly even remember that you came to see me for the pain. So trust us. We know the difference between bad, need to intervene, and simple, and we know what it is. And there's a whole lot of stuff in between. And as long as you're not in that, it's really bad, we need to do something, you need to write it out and trust us.
And it makes a lot of sense that in those early days when people are hyper-focused on their bodies, in your everyday life, randomly your hand might just hurt or whatever, and you're like, that was weird. And you just move on because it's just a part of experience. So it makes sense that in that time you're kind of hyper-vigilant about everything.
Because people do get conditioned a lot of the time through GPs and sort of that sort of culture and Dr. Google, that if there's a problem, we've suddenly got to do a battery of tests and get to the bottom of it. We actually don't. We're both very good at working out if something is very, very serious, and doing a whole battery of tests can often lead you down a rabbit warren that you just don't want to go down. And so often there's not a test or ultrasound, X-ray, blood test that we need to do to help us get you into the right sort of bucket. We just know.
And it's interesting that you said at the start as well, a lot of people don't have experience with a lot of the surgery that we do. However, they do commonly ask their next door neighbour, who may be a ICU nurse or something, or see a GP, and none of those people see these sort of issues on a day-to-day basis like we do. And so if someone's already said to a patient, oh my God, you've got an infection, you need antibiotics, and then they call us and we see them and we're like, this is kind of normal healing red, and it's so hard to get that patient's trust back again sometimes, because it's like, look, we've done your surgery, we know exactly what's going on, we can see this. In our experience, because sometimes it does need antibiotics, sure, that's fine. But in those where it doesn't, then patients feel like they're not being listened to because someone else has said so-and-so had this and that's the right thing to do. So
reassuring to feel like someone is taking action, wait and see. Yeah. It's the same reason why you hate going to the physio, because all they do is give you exercises and you're like, I wanted a tablet.
I want a magic fix. Yeah. We're your surgeons. You've chosen us to do your surgery. If we've done your surgery, then, it takes a bit of a buy-in from both sides that you still have to trust us going forward, and things can change for better or worse. And so if we've said, look, it's okay, but then you get worse, for sure we want to know about that.
These things do evolve. So I had a patient recently, tummy tuck patient, had a little bit of a temperature, but nothing major, felt a little bit uncomfortable, didn't feel totally well. She came in, I saw her, I wasn't overly worried. And this is the important thing. We don't then just say, look, we'll see in 6 weeks. I was not overly concerned, but my antenna was up. And so we arranged to see her, I think, after the weekend. And it sort of had then evolved, and there was a bit of more of a temperature. There was maybe a little bit of redness, and we started some antibiotics, ongoing evaluation. So the ultimate treatment of someone who's got infection is taking them to the theatre and wash everything out and do it. You just can't do that on every single patient that has a temperature or feels a bit hot and sweaty. So this one did evolve, and we did start some more antibiotics. She actually did end up going to hospital, had some intravenous antibiotics, and then everything at this point has resolved. But just because we say everything is fine, we will always make a follow-up appointment to make sure everything has completely resolved. And the office is always open. We both always have our mobile phones on 24/7, 365 days a year. If something changes, you contact us and then we change the plan. It's not a static situation. We don't just see you and say, it's fine, we're never going to see you again. We want to monitor you. And as Kim said, make sure that everything is fine.
Yeah, there's a big difference between what you're doing is waiting. You're not doing nothing. You're not dismissing them and saying, go away, that's enough. It's what we're doing is just giving it a sec and see whether it's worth intervening.
And I know Zeph, our nurse, every time she speaks to a patient, anything changes, contact me if it's in the day, contact your surgeon if it's after hours. And so, it's sometimes it upsets us when someone comes in and they're like, oh, yeah, I'm fine for their 6-week appointment. I'm fine now, but 2 weeks ago I had an infection. And it's like, well, we didn't know anything about this. We would much rather see or hear from patients. And the vast majority of the time, as Richard said, it's it'll settle and it'll be fine. And that's great. But we've seen you at the time where you're concerned, and we can see if it's escalating or getting better.
Yeah, and you want to be in the loop the whole process. Yep. How do you find patients react when you say what you're doing is waiting?
Well, as I said before, I think it's a difficult conversation. That's why I've sort of introduced what are you mainly worried about? Because sometimes there is something in a specific operation, and there are classic things with each operation. And if I can reassure them that that's not the issue, I'm not worried about that, then that sometimes allays their fears. But as you said at the start, it is kind of a scary process. It is a bit of a journey. No one really knows how they're going to react. And plus there's always other things going on in people's lives. You don't 100% know what's happening, how much support they're getting at home, how much the kids are driving them crazy. So, yeah, sometimes you try and reassure them, but it's sometimes, you can't.
Converse to that, there are a lot of people that, with some reassurance are just like, oh my God, that's so good. I feel so much better now. Sorry for wasting your time. We'd never say that you're wasting your time. I'd much rather see someone
I've heard
reassure
you say
them
that.
all the time. It's so much more of a weight off our shoulders to see someone for like 30 seconds and go, yeah, like that's this. It's fine. It's going to get better. It's relieving for them and for us.
Speaking of individual surgeries, what a segue. Okay, what are some common ones you get post-abdominoplasty?
The most common presentation in that sort of 2 to 6 week period, or even a little bit beyond, is a weird tummy pain. Kind of comes and goes. There's no real triggering factors. Patients come in and they're very, very concerned. And that one, 100%, I always know patients are worried that they've ripped their sutures open, their muscle repair has come undone. So I'm worried I've done some damage, like I coughed, I sneezed, took my garment off for a day. It's very easy to confirm with examination that the muscle repair is fine. It's a very, very common symptom to have some abdominal pain after a tummy tuck in that period. And it's actually more common like at 6 to 8 or 9 weeks when you're getting back into exercise and using the muscles again, and everything's got a bit of scar tissue around it, and it's all being a little bit stretched and pulled in ways that maybe it hasn't been pulled in many, many years. And so you get a bit of a funny pain. And it may even be a normal pain that you used to experience, but now you're getting it after you've had a tummy tuck and you think, oh my God, something terrible has gone wrong.
I think just swelling, and it's so variable, and I don't think we can predict who's going to have tons of swelling, who's going to have no swelling whatsoever, fluid in the tissues, which comes and goes it usually increases during the day, overnight it goes down again. So that's sort of one of the main questions that I would say. Does it flatten? Does your tummy look awesome in the morning? And does it get worse throughout the day? Yes. Okay, well that's just normal swell, how I think a lot of patients call it. And I've had a handful of patients that it's lasted 3 to 6 months. It's uncommon and it's uncomfortable and they just want a magic fix. By that time they're like so over it, but it does just sort itself out in the end. And if you're someone that gets no swelling afterwards, then embrace that because you're real lucky.
Before you have a tummy tuck or a body lift, you've got sort of this overhang. And I think all of us, our weight fluctuates between 1 and 2 kilograms a day. So I know if I weigh myself in the morning before breakfast, I'll weigh less than at the end of the day. We've always got these fluid fluctuations. And so before you have your tummy tuck, you have that as well. But if you're a tummy tuck candidate, particularly lower body lift candidate, you've got such a thick overhang that if that increases by a centimetre, it's such a small percentage of the actual thickness of the skin. And then when we remove that, everything's much flatter. And so the amount of skin that you have is much more negligible, or the thickness of the skin. And so if that skin increases again by a centimetre, that's a bigger percentage of the skin that's left. So that might be a 30% increase. So you notice it. So I think some of this swelling, because sometimes patients come in and say, oh, I'm so swollen. And, we all look at them and I look at them and Zeph looks at them and I'm like, you just don't look swollen. It's like, no, I'm really, really swollen. And so I think some of it is a bit of perception. It's getting used to your new body and your new skin shape and that there's not sort of this excess skin.
I think with some of those patients as well, though, because the skin's still numb as well.
Yep.
And so they don't have that normal proprioception of it. I always use the example of if you go to the dentist and you have a numbing injection and you feel like your face is like triple the size and you look in the mirror, you look completely normal. And so it's a similar sort of thing. You don't have that normal proprioception or perception of what it is. So because it's numb, then even a tiny bit of swelling or no swelling, because you can't feel it, it makes it feel like it's bigger and weirder. So I think that contributes to that as well.
Yeah, I think because even sometimes I'm like, whoa, I'm so bloated. That is crazy. But again, I'm just like, oh, that's normal. I know that happens all the time. And also I'm not very fixated. I didn't just go through surgery and that's the thing that I'm worried about. It's just like, whoa, that's crazy. And then you wake up in the morning, you're like, oh God.
It's fine. Yeah. And if you get normal gut bloating and you've had tummy tuck surgery, your insides, the guts part of it is still going to bloat. Yeah. That's your normal, the way your body is. And having the skin tightened isn't going to stop there, but it's going to be more obvious and you're going to be more aware of it and be looking at that area more and kind of forget that it used to do that all the time anyway. And then it's like, oh, it's the surgery's fault.
What about breast augmentations?
So the most common thing I think patients worry about is a capsular contracture. And basically any symptom that they get, they think that's what is heading down that path. So the common things, a bit of discomfort, like the patient I described earlier, a bit of discomfort or tightness, and they think that's leading to a capsular contracture. Generally, that's not how it happens. It's a much slower process. You don't really know that it's happened until sort of you've had it maybe for several months and think back and say, well, hang on a sec, like my breast seems different in shape or size than what it was 6 months ago. That's the underlying concern, but concern presents in a myriad of ways. It is most commonly when patients have started getting back into exercise, suddenly your pectoralis muscle generally has a implant sitting under it. So it's sitting in a slightly different position and the way it's contracting is in a slightly different way. And your body needs to get used to that. And so it might just feel a little bit different.
If they've had breast surgery, their awareness of the potential for breast cancer is a bit more heightened. So none of the surgeries that we do increase your risk of breast cancer in any way. You still need to self-examine all the time and get your mammography and screening as routine. But I think it's a similar sort of thing, like particularly with the breast reduction patients or the lift. But I've also had it with the augment. Obviously, any new lump or any significant change needs to be investigated. But I think they just become hyper aware of that as an issue.
What about breast reductions?
They're usually fairly low maintenance.
Happy.
I think because they've often got a lot of pre-existing shoulder, neck, back pain. And so I think often in those patients, a lot of the pains have been resolved, and we're also we're not doing anything to muscles. I think maybe muscles cause a little bit more discomfort, and we're not sort of tightening the skin like you would with a tummy tuck.
At that sort of final 3 or 4 month follow-up, when we're usually discharging those patients, I spend a bit of time, get to know your new breast, because all the tissue is in different places to where it previously was. And commonly out the sides, where particularly if someone's been very big out the side, an underarm kind of boob, that if you've reduced that, then one thing is they can feel their ribs more. I have actually had a patient come in before going, I've got this really hard lump here, and it was their rib cage that they'd just never been able to feel ever before. For those people, just learn what feels normal for you now, and that's your new normal.
Obviously, people send in photos all the time when they're worried about something. What's the difference between seeing somebody in person or just getting that photo of the kind of localized area?
So I'm not a big photo guy, so I don't get many photos. I mean, occasional photos sent to me, but I think it can be a bit of a trap. I've seen it both ways, where someone sent a photo and it's alarming and I think it looks terrible. And then when you see them in person, it's nothing like that, because the photo is very sort of...
Had a Snapchat filter on it.
Yeah. Well, it's very close up and you don't get the perspective and you don't see the patient on the rest of the patient. And I've seen it the other way as well, where someone sent a photo in and it's ended up being more serious than what the photo would depict. So very old school, I like just to see, and Kim's the same with that. I just like to see the patient. So my default, all the staff, nurse, if someone rings up and there's a problem, I just like to see them. And, a lot of it goes back to my early days of training, and the analogy is really from colorectal surgery. A bit graphic, so try not to think about this too much. But when you had colorectal surgeons, they used to say, if you don't put your finger in it, you'll put your foot in it. And what that means is basically, without trying to unpack it too much, if you don't examine someone properly, you're going to miss stuff. So it's the patient on the other side of the wound that actually matters. I can generally, and Kim as well, can tell a patient sitting in the waiting room, 99 times out of 100, I will be able to say, are you sick or not sick? I know whether I need to be worried or concerned. Sick patients just look sick. So if you've got a little bit of redness, but you are not sick, you don't have objective things like high temperature, rapid pulse, like, above 80, above 90, above 100, and you otherwise look well, then whatever's going on with the wound is kind of like not a big deal. Maybe you need antibiotics, maybe you don't, but you don't get that from a photo. So that's why I like to see the patient. You can feel it. you get a better understanding of, is it swollen? You can actually feel the wound. And so you just can't beat. It's not always convenient for patients, but doing investigations, doing an ultrasound, doing a blood test can't beat actually seeing a patient.
You've spoken before about examination before investigation. Did you want to go into that a bit? And you just told me a really good story earlier about a case that didn't happen. If you could tell us about that one.
So the dogma when you're doing medical training and junior days as a doctor in the hospitals is to always take a history from a patient, always examine a patient before you order any tests. And there's good reasons for that. Firstly, it targets what tests you need to do. Some of the tests are not completely benign. So when you have a CT scan, there's a certain amount of radiation and things like that. But more importantly, if you're just doing like scattergun approach and just doing a whole lot of tests, you can end up going down a rabbit warren, which just you get stuck on this treadmill and it can lead to a bad outcome. And if you'll indulge me, I do have a story.
Notes.
Well, it's a complicated story. She had developed some abdominal pain a year after surgery with me, ultrasound, and they diagnosed a hernia around her belly button. Surgeon took her to theatre to repair the hernia. Pain didn't get better. Sort of 6 months or so after that, pain was still there. She went to a gynecologist. Gynecologist said, yeah, I know what this is. She had a laparoscopic hysterectomy.
Because they obviously thought it was endo, right?
They then thought it was endo. Yeah. She's got this pain. She'd had a hernia repaired. That didn't fix it. So, we'll take out your uterus. That'll fix it for sure.
And how old is she?
I think maybe in her 30s. Then we're sort of like now a year ahead, still got the pain. She's had a gastroscopy. That hasn't shown anything. Abdominal pelvis, CT, another scan. Again, that shows another hernia. The general surgeon went back in and he then did another 2 surgeries, still didn't call me. Anyway, patient ended up addicted to narcotics. So she was on OxyContin or one of them and was taking like mega doses.
And has had tons of surgery that hasn't done
she's had
anything
like
to any of her pain.
much
4
pain.
operations.
Done nothing for her pain.
And she realises she's addicted to these medications. So she actually admitted herself into a rehab.
clinic.
Yep. Got off the painkillers. And I think at the insistence of her mum, came in to see me like last hope, like maybe he'll know like what is going on. Anyway, so I did what I do, took a history, examined her, and then went back and looked at some of the investigations that she'd had done, and where her pain was didn't correlate with where any of the surgeries had been done, and it was in a completely different spot. So I said, look, I think the pain's been this all along and it's kind of been misdiagnosed, and you've had all these surgeries which don't match up with where your pain is. And I think if I just go in and do this very simple repair, it's going to be better. Anyway, went ahead, did it. I think she's maybe 3 months post-surgery now. When I saw her at 2 weeks, she said pain had completely resolved. We actually rang her today because we haven't seen her. We were meant to see her last month, hadn't seen her. She's just got back from Bali. Everything is absolutely fine, but it just underlines what I'm saying. So I think the problem, where it all went wrong, was the initial surgeon heard abdominal pain. It's somewhere in there.
Do a scan.
Doesn't correlate the scan. I actually rang the radiologist who'd done the ultrasound, who happened to be someone I know. I rang him and I said, listen, I think the pain is this. Like, I don't think that there's actually an umbilical hernia at all. So he went through with that better history. And this is why it's important when you're doing investigations, very, very targeted. And he said, no, you're right. That's not where the defect is. It's where you're saying. And so it became a no-brainer to fix it.
And it's just so frustrating because it's not even like she went outside of a normal course of action.
No. Yeah,
like,
she didn't do anything wrong.
If you like your tummy hurt, you would probably go to the first person that did the tummy surgery. And so to have that, and then for them, like they had the right results, but they've just gone down the wrong path.
Well, I think they maybe didn't go back and examine her and correlate where the actual pain was, because where I actually examined her, that replicated the pain exactly. She said, yeah, that's the exact spot, which is where on the ultrasound the actual defect was, which wasn't umbilical, it was just next to the belly button.
And then for the lesson to learn to be that you're addicted to these highly addictive drugs that are overprescribed.
It's crazy. I had nowhere near as significant, but a similar sort of thing. Patient abdominoplasty, it was probably 6 months down the track, had some abdo pain, which she said felt like a muscle tear when she was doing gym, but was bad enough. Oh, she worked in admin in the hospital, so someone was like, oh, just pop down to ED and they'll look at you. Yeah, clearly no one examined her where she said the pain was, did a scan, then call me. I actually got the call, thankfully, saying she's got a hernia, an umbilical hernia, and a muscle dehiscence after her abdominoplasty. And they were offering to do surgery to fix her hernia in this regional hospital. And I was like, no, send her to come and see me. And when I examined her and where she had the pain, it was like under her rib cage. It was like nowhere near her belly button. And I'm like, I think we just need to sit tight and not do any surgery. And she was super grateful and it got better. Thankfully, she avoided, 5-6 surgeries.
And because that's the issue, right? If you're not following that kind of process, then you are doing nothing, because then you just start doing this like unnecessary intervention and nobody wants to be having unnecessary surgery.
And especially if you've got imaging or an x-ray or a test or something that says this is what the problem is, but it's not actually anywhere near what the real problem is.
What's your top advice for patients who have any of the things we've kind of discussed, any concerns in those early post-op days? What is your advice for them?
All right. So I've got 3 pieces of advice. Number 1, call us. Number 2, call us. Number 3, call us. That's it.
And number 4, trust us as well.
Yeah. Well, it's usually 3 things. Look, we want to know. We want to see you.
Yeah.
And like we've done the surgery.
Yeah.
And as Kim said, like, trust
our
us to look
advice.
after you afterwards as well. Like, that's part of our deal.
If you liked that episode, there's plenty more where that came from. Maybe start with some of these or head to our channel for your peek into the mysterious world of plastic surgery.